Hey guys, Don here. Welcome to Podiatry Practice Mastery. Trying to help you get your personal practice up to a $1 million level. I'm trying something a little bit different today. I've been helping some people coaching, do a little coaching with Adam. And one thing that I think he kind of liked, we kind of go over our daily MVP, which is the most valuable patient. So I thought I would share that with you just as kind of maybe inspiration, and I'd love to hear yours. If you want to email me and let me know your MVP, do that at don@podiatrypracticemastery.com. So I'm going to talk about three patients today. First one was a 48-year-old male. He came in with a right bunion that kept on getting worse. He had seen another doctor for a second opinion, kind of history of gout, okay, kind of a little bit red, kind of a large bunion. So he had already tried different types of shoes. He had already owned a pair of Ultras, and he did have Aquinas. Okay, so a few things that I did with him. First of all, for the bunion, we got x-rays, of course. We looked at those, reviewed them with the patient. It wasn't too large that he needed a bunionectomy, and he wasn't looking for that. He was looking kind of ways he could run and be active. So I recommended a topo because it had a little bit of a more of a heel on it versus the Ultras, which are zero drop. They have like a 5 or a 7 millimeter drop on them, which might help due to his Aquinas. So I think Aquinas could be affecting it. So he did the Pelto special. If you keep listening to this, you heard about the Pelto special. That involves a night splint, foam rolling for the back of the calf, and a morning stretch with a towel. Okay, so that's what he did for the Aquinas. He did, because of the bunion, he got an orthotic. So I used forward motion. I did a first ray cutout for that to help the range of motion, and a Cluffy wedge. And he had already tried like bunion splints and pads and correctos and all these things. I also recommended for him, besides the night splint and that, I did a uric acid just to see how his gout was, if he was dealing with gout. And I think I gave him as well a cortisone injection because the joint was painful and had been painful for quite a while with ultrasound guidance. So as you can imagine, and he got orthotics as well. So orthotics, ultrasound guided cortisone injection, for the Aquinas, the night splint, and things like that. So that was his. And the way he found us online because he was looking for doctors, right? And he came from about 45 minutes to see us. So that was most valuable patient number one. Number two was a patient that was here, a 68-year-old man who was here for a fungus follow-up after taking Lamisil. But he said, hey, by the way, I have some pain to the medial foot at the area of the navicular tuberosity. So he had some posterior tibial tendon pain in that region. So what do we do for him? We had him stand. He had pronation on that side. Kind of went through everything talking about pronation, things like that. And so he is starting with once again, he had some Aquinas. So he's doing the Pelto special, foam rolling on the posterior tibial, night splint, or stretch splint, which I call it, and a morning stretch. And also he's doing an orthotic because of that pronation in there to take pressure off. The way I explained it to him is we do certain things to take away the pain and the other things to keep the pain away. So the way we take away the pain was a combination. We're doing a Mobic once a day for 2 weeks, contrast baths, and then that stretching routine. And then to make it not come back, we're going to be doing an orthotic. Okay, that's second patient. And then the third patient was kind of an interesting one. This was a 54-year-old female. She came in. She was here for a second opinion, had been to see a big university hospital doctor. She had a history of stress fractures in the past, pain to the base of the second and third metatarsal. Said she had some like fullness feeling in the front of the foot, kind of consistent with a neuroma. Pain all throughout the diffuse forefoot. On x-rays, it wasn't really obvious what she had going on. I thought a possible stress fracture at the second metatarsal, more towards the base region. And so when I'm unsure, what I tend to do is I use an ultrasound. So I got an ultrasound, and it did show a cortical irregularity at the base. And so we put her back into the cam boot. And because she has like a consistent kind of an issue going on, and this has been her since August, so I don't know if it's a new stress fracture because she's been walking more. That was her main complaint, is she had this pain after she was walking more. She was up to 10,000 steps, 2,500 more than normal. So considering stress fracture in that area, and to help it heal faster, she wanted to kind of speed things up. We set up 4 sessions of shockwave with focus shockwave combo and focus. So I'm going to do the radial on the plantar foot, all around that area where it's all inflamed, and then focused specifically on that stress fracture region to help it heal faster. The way I explain it to patients, I do not do it for every stress fracture, but in this case, she's had a history of stress fractures. She's already on vitamin D supplementation, and we're putting her a cam boot. She wants to get out of that as soon as possible so she can get back to walking. Okay, so I hope this was beneficial. If you have your most valuable patient, let me know. I would share it on a future episode. And if you are listening here, I am kind of trending down towards doing less YouTube just because I don't want to hire people to do all the editing, and I'm focusing more on this this podcast version. Please tell your friends about it. And if you want to learn more, go to podiatrypracticemastery.com. Okay, thanks.